Hello, my name is Paula Rodríguez de Otero. I work as hematologist at the University of Navarra in Pamplona, Spain, and I would like to start by thanking the Saudi Society of Bone Marrow Transplantation for the kind invitation to join you in this Post-EBMT 2023 meeting. I would like to apologize for not being able to be here with you. And my topic today is cellular therapy in multiple myeloma. And I have decided to focus mostly on the latest presentations that were shared in the European Bone Marrow Transplantation meeting regarding CAR T-cell therapy in multiple myeloma. These are my disclosures. So we know that the treatment landscape of multiple myeloma has significantly evolved in the recent years with the incorporation of second-generation proteasome inhibitors, second-generation immunomodulatory agents, as well as anti-CD38 monoclonal antibodies. However, unfortunately, patients with myeloma continue to relapse, and we know that outcomes where patients are exposed to the three main classes of drugs remain suboptimal, with a median progression-free survival that is shorter than 5 months and an overall response rate of only 13% based on the data from the prospective observational locomotion study. We also know that triple-class exposed patients do not have a standard of care regimens, and in this study, 92 unique therapies were used for the treatment of 248 triple-class exposed relapsed refractory myeloma patients. Therefore, novel agents with different mechanisms of actions are needed to be able to overcome multi-drug resistance in the setting of triple-class exposed relapsed refractory multiple myeloma. And this has been the population of patients that was defined as an unmet medical need population in which BCMA-targeted therapies has been developed. And luckily, we do have now 2 BCMA-directed CAR T-cell therapies that are approved both in the European and also by the FDA, that are ciltacabtagene autoleucel, cilta-cel, and idacabtagene vicleucel, or ide-cel. These 2 CAR T-cell constructs were approved based on phase 2 single-arm pivotal studies. So ide-cel was evaluated in a population of 3 or more prior lines of therapy, the majority of them triple-class exposed in the context of the KarMMa study. 3 different doses of ide-cells were evaluated, 150, 300, and 450 millions of CAR T-positive cells, and in the 128 patients that were infused, overall response rate was 73%, with 1/3 of the patients achieving complete response or better. Importantly, patients that were treated at the highest dose level of 450 millions of CAR T-positive cells had a better overall response rate, 82%, and also 39% of the patients achieved complete response or better. Median progression-free survival in all ide-cel treated patients was 8.8 months, and it was longer for patients that were treated at the highest dose level, and also longer for those patients that achieved complete response or stringent complete response. Ciltacabtagene autoleucel, or cilta-cel, was approved based on the data from the CARTITUDE-1 study that also enrolled a population of patients with triple-class exposed myeloma that were exposed to at least 3 prior lines of therapy. The outcomes are depicted here in the slide. Overall response rate among 97 patients that were infused was very high, 98%, with an stringent complete response rate of 82.5%. With a median follow-up that is now over 27 months, the median progression-free survival has not yet been reached in this latest update presentation, with a PFS rate at 27 months of 54.5%. So this study is going to be updated in this European Hematology Association meeting this summer. So regarding the safety, so more or less we can say that the safety profile was comparable between the 2 products. So regarding cytopenias, the incidence of grade 3 or higher neutropenia in the 2 studies was 95% for cilta-cel and 89% for ide-cel. Cytokine release syndrome was very frequent, seen in 95% of the patients treated with cilta-cel, in 96% of the patients treated with the higher dose of ide-cel, but importantly, the majority of the events were grade 1 or 2. The median time to onset for CRS symptoms after cilta-cel infusion was 7 days and was only 1 day for patients that were infused with ide-cel. Neurological complications were less common, seen in roughly 20% of the patients, and 5 out of the 97 patients treated with cilta-cel in the CARTITUDE study developed a delayed neurological complication with movement and neurocognitive symptoms that are not fully understood, but apparently are related to the BCMA expression in the basal ganglia, and that were typically grade 3 or higher. So we do have now real-world data that is being generated, and this is the first experience of the Myeloma CAR T-cell consortium with 159 patients that were infused with ide-cel in the real-world setting. Importantly, as you see here, 75% of the patients that were treated with ide-cel did not meet the KarMMa inclusion criteria due to comorbidities, and despite this, the median progression-free survival was comparable to that of the KarMMa study, as well as overall response rate and complete response rate. In this latest EBMT Congress, the retrospective experience from the EBMT register was also published, and you see here that 33 patients were treated with ide-cel across Europe, 20 patients were treated with cilta-cel, and the median progression-free survival was 12. The median follow-up was 12 months for ide-cel, 7 months for cilta-cel, and 76% of the patients were alive in the last status at last follow-up for cilta-cel, 90% for ide-cel, and you see here that responses are, let's say, comparable to what we see in the pivotal studies. So what's next in the development of CAR T-cell therapy in multiple myeloma? So as other colleagues in the lymphoma and the BALL setting have done, so the idea is to move CAR T-cell therapy earlier in the course of the disease in populations that still have an unmet medical need. And the first of these such populations are patients that are triple-class exposed, but in earlier disease settings. And these are typically the patients that have received at least 2 prior lines of therapy that become refractory to an IMiD and refractory to anti-CD38 monoclonal antibodies, in which the options that we do have approved are not very exciting, let's say. So this is, in fact, the population that was enrolled in the KarMMa-3 study that compared ide-cel against standard of care regimens. Patients with 2 to 4 prior lines of therapy, all of them triple-class exposed, were randomized 2-to-1 to ide-cel or to standard regimens. Patients that were allocated in the standard regimen arm received 1 of 5 of these standard therapies based on prior exposure and prior refractoriness. Treatment was continuous until disease progression, and at the time of confirmed PD, patients could cross over to the ide-cel arm. Patients that were enrolled in the CAR-T arm underwent leukapheresis, received optional bridging therapy using the same 5 standard regimens that were proposed for the standard of care arm, and then received lymphodepleting chemo and ide-cel infusion with a target dose level between 150 to 450. Patients were followed for progression-free survival, and the primary endpoint of the study was progression-free survival assessed by the independent reviewing committee. So this is the summary of the key efficacy data. So the patient population that was enrolled was an advanced myeloma patient population with a median number of 3 prior lines of therapy. Sorry, because here there is a mistake. A median time from diagnosis to a study entry of only 4 years, and over 40% of the patients had high-risk cytogenetic abnormalities, and roughly 66% of the patients in both arms were triple-class exposed. So among the 386 patients that were randomized, 254 were assigned to the ide-cel arm, and this comprised the ITT population, and of these, only 225 patients were infused, and 91 are still ongoing for progression-free survival. Among the 122 patients that were assigned to the standard regimen arm, 126 did receive a therapy, with DPD being the most commonly used standard therapy. So regarding progression-free survival, a single infusion with ide-cel resulted in a significant improvement in progression-free survival with a median of 13.3 months compared to 4.4 months for patients that were treated with standard regimens. Likewise, overall response rate was also superior for ide-cel treated patients with an overall response rate of 71% as compared to 42% for patients that were treated with the standard regimens. And notably, the progression-free survival advantage was seen across different subgroups of patients, including patients with older age, patients with high-risk cytogenetic abnormalities, regardless of tumor burden or the presence of extramedullary plasmacytomas, and also regardless of the numbers of prior anti-myeloma regimens. The PFS benefits was also seen in patients whose disease were triple-class refractory and also penta-drug refractory. Regarding the safety profile, this was consistent with previous report. Hematological toxicity was the most commonly seen in the two arms, with a higher incidence of grade 3 or 4 events, hematological adverse events in ide-cel treated patients as compared to patients treated in the standard regimen. The median time to recovery of persistent grade 3/4 thrombocytopenia or neutropenia was 2 months for the thrombocytopenia and 1.7 months 1.9 months for thrombocytopenia and 1.7 months for neutropenia in the cohort of patients that were treated with ide-cel. Infections were also common in the two treatment in both cohorts, and grade 3 or 4 seen in around 20% of the patients. Of the grade 5 events that were reported, 18 out of 36 in the ide-cel arm and 3 out of 8 in the standard regimen arm were consistent with disease progression. If we focus on the patients that were infused with ide-cel, 225, cytokine release syndrome was seen in 88% of the patients, with the majority of the events being grade 1 or 2. 9 patients developed a CRS event grade 3 or 4, and 2 patients died because of a grade 5 CRS event, one in the context of the candida sepsis and another one in the context of a decline in organ function. Regarding investigator-identified neurotoxicity, 15% of the patients developed any grade neurological complications that were mostly grade 1 or 2. If we move forward to bringing CAR-T cell therapy to an earlier disease setting, another population of patients that continue to be difficult to treat and can be defined as an unmet medical need populations are patients that are refractory to lenalidomide. If we focus on the schemas that we may have available in our hospital, like KD, DVD, or PVD, we see that median progression-free survival for lenalidomide refractory patients is shorter than 10 months. Also, if we evaluate the data from DPD, although this is more of an advanced myeloma patient population, we do see that the median progression-free survival in lenalidomide refractory patients is only 9.9 months. So this is the exact population that was evaluated in the CARTITUDE-4 study. That's a study cilta-cel efficacy compared to standard regimens, pomalidomide, bortezomib, and dexamethasone, or daratumumab, pomalidomide, and dexamethasone in the treatment of patients with relapsed refractory multiple myeloma that has received 1 up to 3 prior lines of therapy and were lenalidomide refractory. We know already that the trial met its primary endpoint of significant improvement in progression-free survival, and the full disclosure of the data will be done at ASCO and EHA this summer. But still, another population of functional high risk are still are still relevant, and we do know that patients that, for example, relapse early after first-line autologous stem cell transplantation continue to do poorly with the therapeutical options that we have today, and there is an unmet need of and a need of evaluating the efficacy of BCMA CAR-Ts in this setting. So here we have data from the cohort B from the CARTITUDE-2 study evaluating cilta-cel in patients with early relapse after frontline therapy. And as you see here, only 19 patients were infused, and overall response rate was 100%, with 68% of the patients achieving a stringent complete response. The follow-up is still short, but 18 months PFS presented in the last EBMT meeting was 83%. We need to wait for more follow-up to see how this early use of CAR-Ts in these populations with poor outcomes really makes a difference. Another population of functional high risk that we know have a suboptimal outcomes are those patients that do not achieve minimal residual disease negativity after frontline autologous stem cell transplantation. So again, ide-cel has been evaluated in this setting. Patients that achieved less than very good partial response after autologous stem cell transplant, 31 patients were treated. The median follow-up of this cohort is close to 30 months. And you see here that the overall response rate was very high. 87% of the patients achieved PR or better, with 74% of the patients achieving complete response rate. You do see here that responses are durable for patients already lasting more than 13 months. And although the follow-up is still short, we can say for a population in first line, you do see here that the PFS curve looks very good with a median follow-up of 13 months. So, so now we know that several BCMA strategies are being developed. And now we do have bispecific antibodies targeting BCMA and also another targets, CAR-T-cell therapies we already discussed, and also antibody-drug conjugates. And more patients are being treated with BCMA strategies today. So the post-BCMA setting, patients that progress or relapse after BCMA-directed therapy represent a new unmet medical need population. And can we use BCMA therapies in patients that have been previously exposed to another BCMA-directed therapy? So the first question that we need to ask ourselves is BCMA still present? So we know that BCMA is shed from the surface of the plasma cell thanks to the action of the gamma secretase enzymes, and that we can follow the BCMA expression using soluble BCMA. So soluble BCMA is a surrogate of BCMA expression, and it also works as a surrogate of tumor burden. So we know that after BCMA-directed therapy and at the time of response, and this is data from the DREAM2 and DREAM1 studies, soluble BCMA levels decrease, reflecting the decrease in the tumor burden. And at the time of disease progression, the levels of soluble BCMA go back again to the baseline level. So in the majority of the patients, BCMA continue to be expressed, and we can follow this expression by measuring soluble BCMA levels. Nevertheless, we are seeing some patients in where there is a complete BCMA antigen loss. So in the KarMMa phase 2 pivotal study, only 4% of the patients that progressed after ide-cel therapy had a complete BCMA antigen loss. So this is still probably not a very frequent and probably not the main mechanism of resistance to CAR-T-cell therapy. Still, we are seeing patients in which there is a biallelic loss of the BCMA locus that leads to a complete loss of the BCMA expression. Therefore, alternative targets or dual targeting may be a way to improve CAR-T outcomes. So what we know about real use of BCMA therapies or BCMA CARs after BCMA therapy. So this is the experience of the Myeloma CAR-T cell consortium. And if you see here that patient that has received prior BCMA therapy, the median progression-free survival of ide-cel was very short, only 3.2 months, and the same holds true in a retrospective experience in the Chicago, analyzed in Chicago, 28 patients, and you do see here that patients that were previously treated with belantamab did very poorly with ide-cel therapy. We have similar information with cilta-cel, and this is data from the cohort C from the CARTITUDE-2 study. And again, we do see that median progression-free survival is shorter, 9 months, as compared to patients that were treated in the CARTITUDE-1, all of them BCMA naive, and also the overall response rate is no longer 98%, but mostly about 60%. So we do see that outcomes of CAR-T therapy after exposure to prior BCMA treatments is not optimal, and eventually dual targeting or the use of alternative targets may be a way to overcome this limitation. So this is experience that is still rather immature, only 16 patients, dual CD19 and BCMA targeting. Overall response rate is quite high, but the follow-up is still very short. Again, so this is a preclinical data from the Barcelona group evaluating a bicistronic CAR-T targeting CD229 and a BCMA. And you do see that in a model that had heterogeneity in the expression of BCMA, with 15% of the cells that were BCMA negative, you do see that the bicistronic CAR-T is the one having a higher survival. So again, suggesting that a dual targeting may be superior to overcome either a down modulation of the target or a heterogeneous expression, or also maybe to overcome a BCMA negative relapse. So also we have other targets, and GPRC5D is a very interesting one. And we have here data from the phase in human dose escalation studies evaluating a GPRC5D targeting CAR-T. The median follow-up is still very short, but I think that the data in patients with prior BCMA therapy is very encouraging. 78% of the patients achieve an overall response rate, 44% of the patients achieve a complete response or better. We do see here that responses seem to be durable and tend to deepen over time. And for sure, this is another attractive alternative for patients that have already received prior BCMA therapy. So to conclude, despite continuous improvement in survival, myeloma patients continue to relapse. And when patients already fail to the three main classes of drugs, outcomes remain very poor, and we need new therapies to salvage these patients. So CAR-T cell therapy, mostly targeting BCMA, is showing impressive clinical results in late-stage myeloma. We have now 2 phase 3 randomized studies in unmet medical need populations in early relapse. The CARTITUDE-4 evaluating cilta-cel in lenalidomide refractory patients, and the KarMMa-3 evaluating ide-cel in triple-class exposed early relapse patients, the 2 of them showing benefit in terms of progression-free survival. Novel modalities with including novel targets, strategies to shorten vein-to-vein time are being developed. And also we know that some phase 3 randomized studies evaluating CAR-Ts as part of the frontline therapy are ongoing. And with that, I close, and I thank you all for your attention.